following along on the theme of value, how important are patient-reported outcomes as compared to provider-reported outcomes? And should we be in the business, so to speak, of following up on the patients in parallel with the other providers to help validate the work that we're doing in the operating room?
Yeah, it's a great question, and it's one that everybody struggles with. And I mentioned Net Promoter Score, and I think does everybody know what Net Promoter Score is? It's commonly used, but it boils down, and there are basically three questions you use. It's developed out of Harvard, and I use it at every one of my companies, but I also used it in a sort of personal relation. But it's basically, would you recommend this service, this person, to someone else, and sort of the ranking of that. And it uses some mathematics to calculate. And I think that is a pretty good bottom line to use. And I do think that you need to talk to both. I think that you need to, you have the provider, you have the patient. We all know the sort of patient rating scores. You know, you can jimmy them, you can play with them, and therefore I think you need an integrated model of being able to go to both and looking at outcomes. We do that, again, I can pick any of the companies, but Teladoc, because we'll do 6,000 consults today, doctor-patient interactions, and I basically decided you need a combination. We need to do follow-up, even though it's not in that phone call, with both the provider as well as the patient, and then get an amalgamated or a combined score. And it gets rid of most of the rough edges, but I think you need to do both.
Thank you, Dr. Weinstein. And Senator Frist, as a Nashvilleian, or a transplant at least, thank you to your family for all of the things that you do for our community, et cetera. As it relates to data, Meaningful Use 1, Meaningful Use 2, and what was Meaningful Use 3 was all geared towards interoperability and really one data source for everybody to use to know, to move forward and to reduce costs. How far away from that are we? We've missed some targets. And do you think it's actually possible with the competitiveness within the different health systems that we have in sharing data?
Yeah, the whole Meaningful Use, the name was just changed yesterday or 2 days ago. What's it changed to? I forgot. Yeah, it was just yesterday. Just yesterday, I was talking to.
Don't get too wedded, and it's going to change again.
Yeah. So data, you don't want to overstate the use of data, but and Sam knows I do a lot in the artificial intelligence world and in machine learning, and what's a deep think, which is sort of the third category of that. And artificial intelligence is sort of the big sort of subset of, or big set of data, and the machine learning is sort of a subset within that, and sort of the deep think, the deep work is within that. So it's an easy way to think about it when you hear these words coming through. But all of it depends on sort of the data and the use of data. And raw data, if you're really good, becomes valuable, but today we're not quite there. So the raw data and the artificial intelligence of being able to sift out good data versus bad data, we're not there yet. We're there in certain areas like Google Maps, or we're using Waze to get over here today. But in the healthcare, it's just early on. So now we have to go back and say, well, the data has to be curated in some way, because we're not smart enough to take the raw data. So 10 years from now, the curation's probably not going to be as important, because the machines will be able to figure out what's good data, what's bad data, and use certain filters, and it'll be a great time. But in the meantime, we have to figure out what is meaningful, what is not meaningful. How should the data be reported? In a world that's very competitive, in this fragmented world that we have in a chaotic world in healthcare, use of data, because it's so valuable, we say, it becomes very proprietary. I'm not going to share my data with anybody. It applies in the hospital system, it applies physician to physician, and obviously it means you don't do cloud sourcing. You don't have the exponential power of being able to learn from 200 people in a room. You just have everybody holding on to their data. I will say, so the meaningful use right now obviously has not been terribly effective. The concept of being able to have more transparency, more accountability to the benefit of individual patients is a good one. We've tried beating people with sticks. We've tried giving some carrots. it's going to get easier with this use of artificial intelligence coming in. So that's sort of the way I look at it. Physicians, from a physician standpoint, productivity has fallen way off with the approach that Meaningful use, where it's mainly filling out forms. Use the quality example of too much. There's a backlash to that now, which I think is very important. As time comes along, it'll get a lot easier. But clearly the use of data has value, proprietary. The sharing of that data means you're giving up something, and people are very scared of that. The power of it, again, is what, like this company Aspire that I built, because if I have 25,000 people out, I learn a lot from that data that are being taken care of. I can develop the analytics. If there are this many people, the problem in setting up a system, I can't wrap teams of people around every one of you, because it would, I'd go bankrupt, the world would go bankrupt, because these are intensive. For every one of you who are going to die within 6 months, I want to wrap 5 people around you. Until I had the analytics to figure out who in this room is the table that I need to focus on, my system was not there. The only reason I can do Aspire today is I have the data, the analytics to be able to predict in a team of 40,000 people, which 25 I need to set up this intensive system. 5 years ago, I didn't have that data, and I didn't have the transparency, and I would have to set that system up for everybody, and the model is not doable.